Good evening, friends. It is end of the day, and the good part is we have studied ending. Last 4 lectures, I believe, are the most powerful lectures of the day. So, all of us are requested, sit back, relax, and enjoy. I don't know whether there is formal cultural program after these lectures are there or not, but I'm sure these lectures would serve the same purpose to all of us. And the current speaker is Dr. V. Mohan. One word that is said every time, he doesn't need any introduction, but one thing I would say that he needs introduction, to the tune that he's a father figure in the country, wonderful orator, researcher, and above all, a wonderful human being and a person who has a very strong connect to himself. With this, I'll not be detailing about the subject. I'll straightforward requesting Professor V. Mohan to proceed with his talk. Professor V. Mohan, please.
Good evening, ladies and gentlemen. First of all, thank you for the kind introduction. Chairpersons, ladies and gentlemen. I wish to thank Dr. Jyotidev for inviting me to be here for yet another presentation, and also MSD for sponsoring this symposium. So I have to tell you that I do work very closely with many companies, including MSD. But I think the majority of what I'm going to say is not really related to the product, but in the end there will be some mention of Sitagliptin. So I hope it's not too much biased. So I'm going to talk on a slightly different note for the majority of this talk, and that is on a topic which I'm very fond of these days: treating diabetes early and aggressively with the idea of improving beta cell function. So this is a slide which from a paper which we published last year in Diabetes Care. And the background of this paper is based on an epidemiological study. We screened some 20,000 people in Chennai doing oral glucose tolerance tests, including a 30-minute glucose test, 30-minute sample with insulin and glucose, and we calculated the disposition index as a measure of beta cell function. And we also measured the HOMA insulin resistance as a measure of insulin resistance. So basically what happened was we went to people's homes, eliminated those who had diabetes or were on any form of treatment, and in all others we did an oral glucose tolerance test. And this is what we found. We had individuals with normal glucose tolerance, impaired fasting glucose, impaired glucose tolerance, IFG plus IGT, and all these are pre-diabetic states. And then, of course, there were many screen-positive people with diabetes who didn't know that they had diabetes until we did the OGTT. The yellow represents the insulin secretion as measured by the insulin disposition index. And you can see the loss in beta cell function in those who have impaired fasting glucose, impaired glucose tolerance or IGT. And when you come to combined IFG and IGT, you can see the amount of beta cell function which has declined even at that stage. And of course, not surprisingly, those who had screen-positive diabetes had the worst beta cell function. Remember, these are people who didn't even know that they had diabetes. So, and the red actually shows you the HOMA insulin resistance, and you can see how the insulin resistance is rising. Somewhere there it levels off. After you get diabetes, it doesn't increase anymore. But the beta cell function keeps going down even after you get diabetes. 10 years later, it's dropping even more. Okay? So 2 things came out from this. One is that beta cell function seems to be declining much earlier in the natural history of diabetes than what we had believed it was. And we have a subsequent paper now in press where we took out this group of individuals, only the normal glucose tolerance people, excluded all of them, and then divided those people into those who had an elevated 1-hour value in the OGTT and those who had a normal 1-hour value. That means some were true NGTs and others were NGTs who had a 1 value abnormal. Fasting is normal, 2 hour is normal, but 1 hour alone elevated. And believe it or not, beta cell function begins to decline even at that stage. So very early, Indians seem to be losing beta cell function vis-a-vis the increase in the insulin resistance as well. We also did some modeling in this and another paper where we did some spline analysis to show that the beta cell function is actually the driver of the the movement from normal glucose tolerance to impaired glucose tolerance and to diabetes. But the big question is this a permanent loss of beta cell function? In other words, once it's lost, is it lost forever? Or are we seeing some kind of an epiphenomenon whereby the beta cell function can actually improve with time? And what we're actually seeing there is not all bad news. And I call this as stunning of the beta cell. The beta cell is just stunned temporarily. It's not able to produce insulin. But if you correct something, it might start working again. We'll see that later. So that's the next question then. Can this beta cell function be reversed by early insulin therapy? So the concept is this. As I showed you in that graph, and this is a theoretical demonstration of the same, there is an observed natural history so that the beta cell function is progressively declining over a period of time. And that's a natural history of type 2 diabetes. So we are asking the question, if you do something early, if you treat these people really aggressively and early, can you slow down that decline? Obviously, you can't make it go up again. That's not going to happen. So can you at least slow it down? And this slowing of the progression of the decline, is it due to early insulinization? In other words, we give insulin early, as soon as a person is diagnosed. Can you do anything to alter that beta cell function? There were numerous studies in the literature, but most of them were very small. They are not randomized clinical trials. They are observational trials, but at least 4 or 5 trials suggested that this is indeed true. So if somebody is diagnosed with type 2 diabetes and give them a shot of insulin initially for a month or 2, their beta cell function seems to improve. But this is the only study I know of, the best study at least in the literature, it's a Chinese study done by Weng et al., published in the Lancet, fairly decent numbers, about 130 people in each arm. What they did was they took newly diagnosed type 2 diabetic patients and divided them into 3 arms. One arm, they gave insulin and also gave it with a pump. So 1 month, they gave newly diagnosed type 2 patients pump treatment. Okay? The other group, they gave multiple daily dose of insulin, 3-4 shots of insulin at the time of diagnosis. The other group, they just gave them oral drugs, like we all do. And what oral drug did they give? They gave glycoside and metformin. So a combination of a sulfonylurea and metformin. Okay? What is not shown here is that the decline in the A1C was similar in the 3 groups. So in a newly diagnosed patient, whatever treatment you give, the A1C comes down to the same extent. But the difference comes in the last 2 columns here, the last 2 rows here. If you look at the delta in the acute insulin response, the increase in the insulin levels, not much different between the 3 groups. Okay, slight decline here, but we can ignore that. There is, when you give pump, there seems to be a slight increase in insulin level. The big difference came after a year. So after a year, if you look at the same insulin levels, okay, the same AIR, the acute insulin response, you can see that in the group which received insulin pump for 1 month, okay, there was only a slight decline in the insulin levels. The group which received multiple daily dose of insulin, again, there was a slight decline in the insulin level. So even there is a decline in the beta cell function. But look at this group. This is the group which we all treat conventionally. We give them metformin, give them sulfonylurea, give them 2 drugs and so on. Almost 60% reduction in the insulin levels at the end of 1 year in the group which did not receive insulin. Based on this, the Chinese guidelines, the Chinese government and Chinese guidelines now says that if the A1C is more than 8.5%, in patients with type 2 diabetes at the time of diagnosis, you should give insulin for about a month. They believe their data. So they said, we don't care, the rest of the world doesn't say it. It's our study, we believe it, and therefore it has come in the Chinese guideline. Well, there are studies going on, the RISE study and the GRADE study and so on. Huge studies are going on in the US. We'll have to wait until very big powered studies are done. Millions and millions of dollars will be spent. And let us see what those studies tell us. We don't have the evidence except this. Okay? Now let me show you in clinical practice what happens. Now this is a 53-year-old male, 8 months duration of diabetes, central obesity, only on glycoside, 80 milligrams BD. Uncontrolled diabetes, fasting is 217, postprandial is 344, A1C is 11.4%. What I did in this particular patient, one of my first in a large series now that I have, I started this patient very aggressive treatment. Okay, I added Sitagliptin, I added metformin also, to this particular patient and gave insulin also for 4 weeks. Why? Because the A1C is 11.4. If I had only 1, I know about 1% reduction I'm going to get. I'm not going to be happy with 10% or 9%. I said I'm trying to normalize the insulin for this particular patient, and therefore we'll hit hard. And I believe that these kind of blood sugars, the chance of hypo in the first 1 month is going to be very small because of the glucotoxicity. After 4 weeks, we stopped the insulin. The oral drugs alone were continued. Let's see what happened. This is what happened. The A1C dropped. With all this that we did, it only came down from 11.4 to 7.1. It's still not normal. Okay? So if you had, I would put it to you, okay, patient came on glycoside. You added one metformin. That's what we'll normally do. It's not aggressive enough. It's going to drop from 11 to 10 or 11 to 9, and we're going to be very happy saying that we reduced 2% A1C. It's not enough. You really have to hit it harder. Okay? Now, this is okay. Now, what happened to the beta cell function? That's what we're talking about. Now, I had the fasting C-peptide, which we routinely do. Fasting and stimulated C-peptide is something which we routinely do at our center. So we had measured the fasting C-peptide, which is quite low, and the stimulated C-peptide is also quite low. Our normal value is about 3.5. So 3.5 to 4 would be like a normal person or somebody who has good beta cell function in the case of type 2 diabetes. So this is what it was, less than 50% of beta cell function. What happened in this patient after all this we did was that there was a fantastic improvement in the fasting C-peptide, and even more impressive as far as the stimulated C-peptide is concerned. If you now go back to the values of insulin which I showed you in the first graph on that large epidemiological study that we did, there were screen positive patients who were at the bottom as far as C-peptide and insulin were concerned. They seem to be now recovering. Once you aggressively treat the glucotoxicity, the beta cell function seems to be improving. Okay? So, this is what I would like to refer to as a concept of functional recovery of the beta cells. Nothing much has happened. We have not done an islet cell transplant here. We have not done anything here. But the beta cells which were not functioning earlier have now suddenly started functioning. In other words, they have recovered from stunning. And I always give an example of this, of the bee. And people like that example when I say that. So I just say that, okay, there's a bee flying around here, and you hit that bee. Okay, just tap it. You don't crush it, but you just tap it. And the bee goes and falls there. And for a moment you think that the bee is dead. Okay, but the bee is not dead, it is only stunned. And after a few minutes, the bee flies away when the stunning effect is over. I would put it to you that something like this is happening to the beta cell. When there is glucotoxicity, when it's surrounded by all this glucose, it's not able to put out insulin. If you remove all that glucose, it then recovers and is able to put out the insulin. Now, how long will this last? Is this something which just lasts for 2 months, 3 months, and so on? Here is a study from Dallas, which looked at beta cell function preservation after 3.5 years after an initial period of intensive insulin treatment. And I think the conclusion is blown up here, where you can see, I'll read it. Beta cell function can be preserved for at least 3.5 years with early intensive therapy for type 2 diabetes with either insulin plus metformin or triple drugs, but that's the bottom line, after an initial 3-month based treatment. So these people were given 3 months of insulin, and then the insulin was withdrawn. And then irrespective of whether you continued insulin or you just gave oral drugs, after 3.5 years, their beta cell function, as shown by C-peptide, was kept much better than what they initially had. So not only it recovers temporarily, but for 3.5 years. I'm sure now longer data will be coming, but this is the longest data we have in the literature. What's going wrong? Okay? And there are some very elegant studies. This is from the Cell by Talchai et al., a fantastic paper which was published. So what these authors showed, that it's this transcription factor, the FOXO1, which is responsible for the beta cell to remain as a beta cell and to secrete insulin. And that's shown in green. Okay? But when you have metabolic stress, and this stress can be glucotoxicity, sugars being very high, what happens is the FOXO1 goes away. So when the FOXO1 goes away, the beta cell converts itself into an alpha cell or a delta cell. It's going into hiding. It's like going behind a curtain. It goes and transforms itself. It de-differentiates itself into an alpha cell or a delta cell. And obviously the alpha cell and the delta cell don't produce insulin. And therefore, it is now not producing insulin. So what happens is, that if you now have this beta cell, you have the metabolic stress, some amount of beta cell exhaustion is occurring, dedifferentiation has occurred. At this stage, if you treat it very aggressively and if you relieve the stress, it goes back. It converts itself back from the alpha cell and the delta cell back to a beta cell and now starts secreting the insulin. And that's why it is not producing the insulin. Not because it's dead, but because it's taken a different rubum. It has transformed itself into something else. Now it has transformed itself back to its beta cell and it's able to produce the insulin. Now you may ask, okay, what happens if you don't do that? And it goes on and on. What will happen is, it will go on and on. More and more metabolic stress will set in. At some stage, apoptosis will start occurring. The beta cell mass will start going down. The beta cells will die. And then thereafter it can't come back. Once it's dead, it's dead. Okay? Then it becomes permanently insulin deficient. And then you need insulin throughout your life. And this is the stage of structural damage. This is the stage of functional damage. So nature gives us an opportunity for some time to intervene. And if you intervene there, then you can do good. If you wait too long, then it's too late. So the last part is okay. With insulin, you're able to do it. Can you do it with any other drugs? Well, there are drugs, and pioglitazone, for example, has been shown to be quite friendly to the beta cells. Anything which doesn't drive the beta cells is quite good. Of course, we don't have long-term studies on them, and we know all the side effects that you have with pioglitazone and so on. But then the incretin-based therapies are something which, and probably in the future, the SGLT2 also will have to look for data. But there is emerging data that the GLP-1 analogs and the DPP-4s might be able to help in this beta cell recovery process. Just one slide on liraglutide, because I spoke about it this morning, is that there is animal evidence as well as human evidence to show, and this is a human trial, showing that when you use liraglutide, there is actually improvement in the C-peptide and in the beta cell function. What about DPP-4 inhibitors? There is evidence that in our population, in Asians, and particularly in Indians, where the beta cell function seems to be a major defect, as I showed you from an epidemiological study, use of the DPP-4 inhibitors seems to be more efficacious than in the Western Caucasian population. In the West, whichever of the DPP-4 you use, Sitagliptin, Vilda, Saxa, Lina, these are the mean reductions in the A1C, 0.5 to 0.7%. Very rarely has a Western study shown that a DPP-4 actually reduces A1C by 1%. Very rarely you will find that, okay? But in our first study, which we published, the first study we did India, China, and Korea, and I was the first author of that, we published in DRCP, we showed that in Indians, the reduction was 1.36%. This has never been shown in a Western population. In the Koreans, it was exactly the same, 1.38. In the Chinese, it was lower, okay? So at least in two populations, and in that paper, we suggested for the first time that perhaps the DPP-4 inhibitors are working better in our population than in other populations. Then a series of studies started coming, and I'm not showing you that, but there were at least two papers in the Lancet which are showing that Asians respond better to the DPP-4 inhibitors. There's been review and the meta-analysis as well which has been done to show that clearly Asians seem to be doing better with the DPP-4 inhibitors. I'd like to share with you another study. This is a real-life study which we did on 1,654 patients, mean age 55 years. This is a real-life study. It's not a randomized clinical trial. We just kept adding sitagliptin to various therapies. It could be sulfonylurea failure, metformin sulfonylurea failure, metformin failure, and so on. And the criteria for adding sitagliptin was an A1C more than 8.5%. And the reason we wanted to do this is, okay, if a sulfonylurea fails, is there any scope for using sitagliptin? This is published in Diabetes Technology and Therapeutics. And you can see this is the mean of these 1,600 patients over a period of time, 2 years. And you can see from 8.9%, there's a reduction to 7.73%. So these are bad patients. These are recalcitrant patients who were really badly controlled. And even in these patients, about a 1% reduction in A1C after using the DPP-4 inhibitors. I'm not going to talk about the TCOS trial because many people are going to talk after this, but the good news is, and I'll skip these 3 or 4 slides, the good news is that we have the recently published TCOS trial which shows the cardiovascular safety of these agents, which the next speakers are going to talk about. I'm not going to belabor these slides. And also, there is some good news with respect to pancreatitis as well as pancreatic cancer. Pancreatic cancer actually being more in the placebo group than in Sitagliptin. Very slight increase in the acute pancreatitis, which was not significant statistically, which other people are going to speak about. I'm just going to be provocative and add this particular slide, and if you don't agree with me, that's fine. But this is just a viewpoint which I'd like to put across, that when you have lifestyle and metformin and the A1C is more than 7%, I've added a line here and said the patient can afford, because a lot of patients can afford. So the patient can afford, and if he's non-obese, I would first try a DPP-4 inhibitor. Okay? If the patient is obese, I would try liraglutide. Okay? Because you can get some weight reduction. Of course, you can also use the SGLT2s and so on now. If the patient cannot afford, then I would add a sulfonylurea, but I wouldn't use huge doses of it, because I showed you even in this presentation that using large doses of sulfonylureas does tend to kick out all the insulin and dry up your pancreas. Okay? And if these are not controlled, then you can consider insulin. Of course, there are many other drugs you can use. You can use AGIs, you can use glitazones, you can use all kinds of drugs. I'm not going to get into that, but just a working hypothesis. So I would like to end, ladies and gentlemen, this part of my presentation here and say that one should consider a short course of insulin in all newly diagnosed patients with an A1C more than 8.5. 8.5 is an arbitrary figure. We'll know whether it should be 8.5 or 8 or 9 from the bigger studies which are going on. But basically, glucose toxicity seems to set in when you have 8.5 and above. Even 1 to 2 months of insulin therapy can work wonders as improvement in both beta cell function and insulin resistance occurs. This new paradigm may help, at least in part, in reversing the natural history of diabetes, the effect of GLP-1 analogs, DPP-4 inhibitors, and newer molecules like the SGLT2 inhibitors on beta cell function needs to be studied, and we have more studies coming. And the safety of sitagliptin has been established by the TCOS trial. And on that note, I hand it over to the next speaker. Thank you. Absolutely. So the second one first, it's very similar. You're absolutely right as a cardiologist that the stunning that you get, in fact, the term is borrowed from your literature, that this stunning can actually be reversed, like your ischemic preconditioning or whatever. So it's a very similar analogy. It's a very loose analogy, but something very similar. Legacy effect, what I showed you is not really legacy effect, it's actually improvement in beta cell function because you're correcting the glucotoxicity. But yes, that leads on to the legacy effect or the metabolic memory, because if you early in the disease bring the glucose levels down very nicely and the A1C is down to near normal, which is very difficult to achieve. Normally because this magic figure of 7% is put down, we tend to be very happy with 7% even at the onset. Some of these patients with early and aggressive treatment have gone down to 5.5%. 5.4% without hypo, because that's the stage in the natural history just after diagnosis when they really respond well. So if you bring it down that low without even hypoglycemia, a year later it can be 5.8, 3 years later it can be 6, 5 years later it can be 6.5, 8 years later it can be 7. So you've got all that time when you're actually keeping the levels really low, and that is a legacy effect which we can try to build. If in the beginning itself you're getting 7.1 and 7.3 and you're happy with that, a year later to get 8 will be difficult, a year later to get 9 will be difficult. You're building a very bad metabolic memory. So yes, you're partly right that when you're really bringing this down, you're actually setting the stage for good legacy effect or good metabolic control. Any insulin is fine. So you really don't need, what Weng showed is that 3 times and 4 times insulin and so on. There are subsequent studies which have come which shows that 1 shot of insulin is enough. Just use 1 basal insulin and that itself is able to do the job of this. So I very rarely use 3-4 times insulin and so on. I just add 1 supplemental insulin. Usually it's a long-acting basal insulin, and that works very smoothly and doesn't produce hypo. I normally use it, if the A1C is around 8.5 to 9, I use it for 1 month. If it is 11, 12, I use it for 2-3 months, but never more than 2-3 months. Yes, sir.
Sir, I am Dr. Samath from Guwahati.
Yes, sir.
I would like to ask you regarding this beta cell preservation.
Yeah.
Sir, you said giving insulin for an initially diagnosed diabetes when it is over 3 months will preserve that beta cell for three to
3.5 years. Yeah.
Suppose if you reduce by 3 weeks,
Yeah.
can it preserve, or is it proportionate? Like if you give more duration,
Longer time, yeah.
you get more duration of beta cell
Yeah.
preservation.
So since we have only the Weng study, which is a very short-term study, we have the Dallas study, which is the only study where they gave it for 3 months. We really don't know, and we cannot extrapolate from there and say if it is for one month, it will be only for 1 year. All that is extrapolation. We really don't know. The GRADE and the RISE studies are designed just for that, and it will look at, they're so much powered that you can then do all kinds of post-hoc analysis to see how long and so on. In general, what I use as a thumb rule is, if the A1C is very high, okay, then it takes a long time for it to come down also. If it's 13 at diagnosis, if you just give it for 4 weeks, it's probably not enough. I've seen the beta cell only recovering little bit. So the higher the A1C, I would tend to give it for 2 or 3 months until the A1C really comes down to normal, and then I'll say you can stop it. But if in the beginning itself is only 8.5, 8.6, even 4 weeks seems to do a fantastic job. I think at present it's a pure clinical decision, but we'll have to wait for long-term trials to come.
I think next talk is a very fascinating talk. We are talking about a molecule about which we don't talk much. Glucagon, the missing piece in diabetes management. And for the last 1 decade, we've been talking quite a bit about it. We have a very eloquent speaker to deliver this talk. Professor Sheshadri is a professor of internal medicine and endocrinology and diabetes and metabolism at Sri Chandra University. He has done his fellowship in endocrinology from Cole County Hospital, Chicago. He is on the is an editorial member of the Indian Journal of Endocrinology and Metabolism, and is currently also in the Executive Committee of Endocrine Society of India. Dr. Sheshadri.
Thank you. Someone told me that this is a star-studded evening, and there are lots of stars here. I'd like to consider myself to be the planet among the stars. So I'm living off the reflected glory of these stars. This is my conflict of interest. It's very interesting to talk about glucagon. I was a fellow in endocrinology somewhat long ago, more than 17 years or 18 years ago. And we have these class discussions where the fellow had to research and present. And my teacher, Dr. Uday Kabadi, said, "Why don't you talk about glucagon?" And our other attending, Margaret Otto, who we liked each other like broccoli and cheese, said, "What is there to look at glucagon?" And Dr. Kabadi said, "I promise you that glucagon is something that we will all know more about and will use in treatment." And he did a lot of work on glucagon. He's probably laughing his way to the bank right now. The other person who did this and spent a lifetime on glucagon was Roger Unger. And these are the only two people who believed in glucagon that I ever knew till recently. The fact is that glucagon is probably older than insulin in terms of evolution. That evolutionary, it has been present in mammalian cells longer than insulin has been. Insulin is a relatively new drug. That's why it requires the action of FOXO and PDX to become a beta cell. Why? Because of the physiology. This is where I would start. And just for you to know that there is, we know so little about we have been studying diabetes for probably more than 100 years ago. Scientifically, and if you want to go as far as Claude Bernard, much earlier. But how much do we know about the milieu of the pancreatic beta and the alpha cell? Very little. Because these pathways are so complex, they are so redundant, that if you make one assumption, you're likely to be wrong, because there are multiple pathways that connect. And as Dr. Mohan talked about, and these are ambidextrous. The alpha can become the beta can become the alpha. There's a whole bunch of stuff that are occurring. But the principal function is that insulin has to reduce glucose and glucagon has to increase glucose. And evolutionarily, decreasing glucose is less important than increasing glucose because we've been starving for many centuries and we've been feasting only for a few hundreds of years. So let's go back to Roger Unger's definition of diabetes. Diabetes is caused by insulin deficiency, amount or effect, and glucagon presence or excess. For the last 40 years, Roger Unger has been saying that there is no diabetes without glucagon. And he's been trying to prove this, and finally his lab proved it in 2010. But that story I'll come to in a moment. So this is from the JCI 1961, where Roger Unger brought this first article about abnormal alpha cell function in diabetes and its response to insulin. Let me backtrack and look at why I say that glucagon is older. The reason we've not been able to study glucagon is if you give streptozotocin and destroy the pancreas, insulin is gone. The alpha cells are also gone, but glucagon is present everywhere else. It's present in the intestine, it's present in the brain in a different form, and there are peptides that behave like this, which based on which drugs have been made for many, many years. For the last 10 years, we've been using GLP-1 and DPP-4. So this is why it's been so difficult to study glucagon. But we now know, and the only way we found out about what the functions of glucagon are by not destroying glucagon, but destroying its action. So if you knock out the receptor for glucagon, you then figure out that glucagon has many functions. One second. We know that in the brain, it increases glucose, so it's very, very crucial there. In the kidney, it increases GFR. It decreases gut motility. Its predominant action is as an insulin resistor in the liver. And I shall show you, if there's no glucagon in the liver, insulin does its work very quickly and runs away. In the adipose tissue, it causes lipolysis. And in the cardiac muscle, it has some effects. But you will notice that these were all designed for a time of poverty. In today's world of plenty, glucagon has become a bad guy. Isn't it? So let's move forward. Now what Roger Unger showed, and this is again from his work from many, many years ago, is this beautiful phenomenon. That for everything that insulin does, glucagon does the opposite. It's like a mirror, When glucagon goes up, insulin goes up, glucagon goes down. When insulin goes down, glucagon goes up. And this has been occurring for many, 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 many years. What Roger Unger didn't have the way to prove is whether insulin is controlling glucagon or is something else happening. So let's look at this. The first thing that we know is that there is a reciprocal calcium signaling that is occurring in the pancreas. That whatever is happening in the beta cell, there is something that is simultaneously happening in the alpha cell, but exactly the opposite. But what we also know is that not only is there a problem with the beta cell in diabetes, we now know that there is a problem with the alpha cell in diabetes also. Look at this. This is the control. This is insulin. This is glucagon. And as I said, this is exactly the mirror opposite. But can you see what is happening here? In diabetes, this relationship is gone. This beautiful synchrony that occurred between insulin and glucagon is lost. Because we had no use for glucagon till the pharma company started making gliptins, we ignored it. But it was always there. So just to take Roger Unger's work, look at this. This is normal. As insulin increases, glucagon decreases. But see what happens in type 1 diabetes. There is no insulin, but the glucagon rises. And Roger Unger's theory was that if there was no glucagon also, then you will not have the metabolic phenotype of diabetes. And I'll show you how he showed it. So what he said was that the metabolic effects of diabetes are not because insulin is less. The metabolic effects of glucagon, of diabetes, are because glucagon is more. In fact, there's now new data that shows that even if there's no insulin or insulin, GLP-1 can do its action. This is type 2 diabetes. You will see that insulin is present, but glucagon is not going down. This is interesting data, isn't it? This is a slide I'm sure every one of you have seen, because this has been exploited by pharma companies for over a decade now. Just shows the reversibility of insulin action and what happens. But what we now know is that the word that they have used is the inability of insulin to suppress the postprandial peak that occurs with glucagon. That normally glucagon would rise, insulin's job is to suppress it. If it doesn't happen, then this happens in diabetes. I'm not so sure that that's what's happening. Because one of my colleagues from the University of Texas, Franco Foley, showed, and subsequent people have showed, the question is whether beta cell defects came first, or was alpha cell hyperplasia there even before that. This is data on apes, where he showed that as the BMI increases, the glucagon secretion increases, then even before beta cell dysfunction occurs, glucagon excess occurs. And this data has been replicated in vitro studies. I haven't shown it, where it seems to be that alpha cell hyperplasia predates beta cell dysfunction in patients with type 2 diabetes. So we really don't know which came first. So this is this big picture, that there is a jugalbandi, a quadruple bandi that is happening there, where multiple inputs are controlling the alpha and the beta cell. I haven't even talked about the brain, which seems to be the most important. Everyone talks, when I was a fellow, I've always wondered, this is an endocrine system, but there's no pituitary control of the pancreas. And then I realized that nature thought it was even more important that it created the control not in the pituitary but in the hypothalamus. The relationship between the alpha and the beta cell is controlled by itself as a paracrine hormone, by each of these cells as an intracrine hormone. We know that glucagon and insulin control their own secretion. And on top of it, these are controlled by hypothalamic signals. So, when you take some pieces of information from here and there and try to put it, then it means that you're looking at the elephant halfway. So there's a lot more that is going on. This is really what is happening. There are a whole bunch of channels and each of these are communicating. I can spend an hour explaining it, but I don't think your dinner is going to allow that. So what I'm going to do now is to say, first we've realized that it's so difficult to understand the alpha and the beta cells and the relationship between them. It's better not to stay there. Instead, move to the action area. Roger Unger tried for many years to look at the alpha and the beta cell. He wasn't able to figure it out because what was happening was that there were too many glucagon producing cells in the body. So he said, let me go destroy what is happening in the end. And this is the glucagon receptor. What we finally did was, you inactivated the glucagon receptor, see what is happening. The plasma glucose went up, the OGTT went up, the insulin is down. Look at what is happening. When there is no glucagon receptor, the free fatty acid didn't go up. The PEP-CK mRNA, which is a marker of insulin resistance in the liver, did not go up. In fact, something very interestingly happened. When you don't have a glucagon receptor, there is no increase in lipolysis. There is no increase in non-esterified fatty acids. In fact, there is none of the effects of diabetes that you see. So Roger Unger, after 40 years of work in 2010 said, in the absence of glucagon action, insulin deficiency is a silent disorder without overt or metabolic consequences. Fascinating. How would one man devote an entire lifetime to this and at the age of 80 hit the jackpot? I think that's the beauty of research. So we now know that glucagon is something very important. And its actions are what cause diabetes. That without glucagon, you don't have diabetes. Which means if you antagonize the actions of glucagon, you actually help the patient. Which is what DPP-4s do, which is what GLP-1s do. GLP-1s do it beautifully by making sure that it brings down the glucagon, but when the glucose goes down, it doesn't suppress it further. The DPP-4s decrease glucagon. And we now know that it's not just the DPP-4s and the GLP-1s, which you're going to hear a lot about today, but leptin. There's a very interesting article that was published in PNAS that showed that leptin can be used as a treatment in type 1 diabetes. How does it do that? Leptin actually increases the sodium channel in the alpha cell. So decreases glucagon production, remember I said, without glucagon, type 1 diabetes is a disease that has no metabolic consequences. Proof of action, use of leptin. Leptin works on the alpha cell, it does not increase insulin in the beta cell. Interesting, isn't it? Even more interesting is what we have this year. I don't know if you read this. This is in July 2015. This beautiful discovery that was published that is called ranolazine. I'm not a cardiologist, but cardiologists use it as an anti-anginal agent that reduces the A1C by 0.5, doesn't cause weight gain, doesn't cause hypoglycemia. And guess what it does? It's a sodium channel blocker. It works at the level of the alpha cells and reduces glucagon production. So we now have two classes of drugs that work on glucagon. One is DPP-4s and GLP-1s and all of these, but the new kid on the block is ranolazine, which is an anti-anginal agent. So this is actually the first time. Remember that the DPP-4 evidence was indirect. We knew it only from conjecture. But after we knew about glucagon's action, for the first time we have a drug that we know directly works in the sodium channels in the alpha cell and reduces glucagon. And you can see that there's a difference between glibenclamide and glucagon here. So I told you about leptin. So the big race now that includes every pharma company in this hall and in this slide is to find a glucagon receptor antagonist. I'll tell you that is not going to be easy, simply because, as I said, glucagon is everywhere. It is an old hormone. It's like PTHRP. Parathyroid-related peptide is something that is found in endochondral bone. It is found in the brain. It has so many different stuff. And we know that it has some critical effects on muscle and liver, especially on fat. And if you muck around with it, it's difficult to achieve. But can it be done? Yes. So the search for the next 10 years is to find these small molecules that work on specific parts of the glucagon receptor that only will give you targeted action. This is where the future is. But as for the present, we at least know a little more about diabetes. And it also gives me a lot of things saying that, yes, not all the work in diabetes has been done. That we have enough work for us, for our children and our grandchildren. And we'll never know enough about it. And the most wonderful thing about research is not knowing enough. It's like wearing a bikini. You need to conceal the obvious. And the search for it is the fun. But it's also reassuring that the therapies that we have today are actually addressing some of the important and fundamental pathophysiology of diabetes, which is insulin, which is very important, but also something older than that and probably causing the metabolic consequences of diabetes. And that is the reassuring note. I know this is a basic science talk. I hope you didn't mind me talking so much hormones. I didn't show you any other studies. But sometimes going back and digging deeper and understanding physiology helps us understand disease and helps our patients even more. So with that conviction, thank you for your time. I hope this was useful for you. Thank you.
That was a wonderful talk. So the planet has become a star today. I can promise you that. It brought in some major nostalgia in me. The first time I have ever heard an endocrine talk in my life was in 1976. I was an intern. And it was Roger Unger talking about glucagon and how he discovered it in Srinagar.
That's true? Wow.
In Srinagar in 1976 summer. That was the first, in 1976, the first endocrine talk I heard in my life. I was an intern. And it was Roger Unger talking about how he discovered glucagon in Srinagar in the summer of 1976. I so vividly remember it because two fellows from our college attended. Me and my friend. The other one became a professor and director of oncology, medical oncology at University of California, San Diego. And that probably set the ball rolling and primed our brains right in time how to look at science. If you look at glucagon, right from 60s, if you dig back, data is available on glucagon and diabetes, and then used to be called insulin-dependent diabetes and non-insulin-dependent diabetes. I distinctly remember in 1983-84 doing one Saturday morning a 2-hour symposium about glucagon and how the mechanism in type 1, current type 1, and then insulin-dependent diabetes is different in patients than in those who are non-insulin dependent. You are absolutely right. We did not talk about it because we didn't know how to intervene. We did not talk about it. Probably the ramifications of this elevation were not known. But we did talk about that diabetes, both type 1 and type 2, are bihormonal disorders all these years. But it did not sink in because we had no mechanism of handling glucagon. There wasn't an intervention available. On the other hand, insulin therapy kept on increasing, becoming better, and we missed a huge link. So you restored that connecting link today. Please join me here for any question. I'm sure you know it was a relatively basic talk.
I just wanted to add that there was one more therapy I did not talk about, and that was something that we started doing from last year. That's the bionic pancreas. The bionic pancreas is an iPhone-related device that, and one more for the iPhone, which actually gives the patient a delivery of both insulin and glucagon. So this is the big thing happening. Any other questions?
Any questions or clarifications? Yes, Professor. Can we have a mic there?
Do you use ranolazine in clinical practice as an anti-glucagon effect, and in what dose?
I would love to, sir. At this point,
what is the action of the function of the delta cell of the pancreas?
we'll do another symposium on the delta cell one of these days. I think, if the beta cell is like deciphering a Rubik's cube, the delta cell is like playing mist at the 30th level. So don't even get me there. It's a delta cell. Have I used ranolazine? No. I mean, the first important clinical trial was just published 1 month ago. I'm actually waiting to talk to a couple of cardiologists to see if they use it and if there are any side effects like headaches and stuff like that. I heard that it doesn't cause headaches. I heard that it is very, very well tolerated. Anybody has experience with ranolazine here? You use, so maybe you should talk about ranolazine because the same dose is used. Maybe you can tell him about ranolazine.
No, I think it is useful in dose of 1 to 2 grams in patients with chronic stable angina. But the only caution is that it may increase the QT interval.
Okay.
But it's not of much clinical.
I have, Dr. Mohan, you have any clinical experience with ranolazine? We are basically people who don't do acute medicine, so you guys are the experts on it. But this was just published about 15-20 days ago.
Yes, any questions? Any more questions? Clarifications?
I'm sure I confused you more than you may need to. Thank you, sir.
Thank you very much. If there aren't any, we move on with it.
It was nice, Jugalbandi, Dr. Krishna. I enjoyed. And this basic science was served in a very lucid way. And with this, we move to another star. And that is Dr. Avdesh Kumar Singh. And he's going to speak on modern type 2 diabetes management, the expert guide to the universe of choice. So diabetes has become something like modern day consultant. When he finishes one task, 4 tasks are already there and he's not able to take up all 4. He moves up with 1 or 2 or 3. So with this, the short introduction of Dr. Avdesh Kumar, he is a very powerful speaker, I believe. Very aggressive, powerful, and very much liked speaker across the country. He is consultant in GD Hospital and Diabetes Institute, Kolkata. He is chief consultant endocrinologist and diabetologist, Sun Valley Diabetes Research Center and Hospital, Guwahati. And he has been a speaker in all Indian meetings. Dr. Avdesh, please.
Thank you, Chairman, sir, for the kind words. Thank you, Dr. Jyoti Dev and team for inviting me. I am back for the next talk. Well, so in this, the group of galaxies of stars, I'm not at all a star. I have not yet been born as a star. But my job is a little bit difficult, and it's not a physiology or, theoretical discussions of science, but it's actually a fight. And with the fight is that nobody is able to decide till date. See the ESD 2015 algorithm, and when the question was asked what after metformin, nobody knows the answer because you have got everything after metformin. So who I am to give you and suggest you what would be the ideal drug after metformin? You have seen this slide up to a number of times, and as I said, I mean, for last 60 years, nobody is able to decide. And that is the reason why ADA ESD suggests that any drug which you feel would be suitable to your patients in front of you, you go for after metformin. But then there has to be some logic and idea what would be the drug after metformin in patient X, in Y, in Z, in A and B. And there has to be some science behind that, why this sixth drug right now has been put into the second line drug. Because I am talking about what after metformin in terms of oral drug, so I will skip the injectable. GLP-1 analog is one of the good regime after metformin in patients, those who are obese, but we know this is a costly drug. Insulin, as Professor Mohan told you, at any time, at any point of time, you can use it, so I am not going to take injectable. When it comes to pioglitazone, alpha-glucosidase inhibitor and bromocriptine immediate releasing, I am not going to talk because they may not be an ideal drug to use after metformin because of a variety of reasons. But having said that, there are a good subset of the patient who respond well on pioglitazone, on alpha-glucosidase inhibitor, typically in this part of world where we are predominantly carbohydrate eaters. So I will skip during my talk this 5 agent, including injectable, what after metformin, and I will take SU, DPP-4 and SGLT2 inhibitor upfront to decide and to give you data in front of you, what would be the ideal drug. But the point is, how to decide? ADASD could not decide for so many years, so there has to be some way to look into and to progress further. So the question is how to answer this question in this evidence-based era. Simple answer for me, you look into the trials where head-to-head these molecules were compared to each other. So you look into the head-to-head trial of SU versus a DPP-4 inhibitor and try to know what happened in these head-to-head trial. Look into the data of SU versus SGLT2 inhibitor and DPP-4 inhibitor versus SGLT2 inhibitor. If we can, put a cross-sectional look on this head-to-head trial, we may be able to generate some idea that what would be the ideal drug. As I know, any drug can be used after metformin. So let's look into the science behind that. But before I go into that, let me warm up you. You all know about this, what we have known so far about sulfonylurea. I wrote a review article just compiling all this data in one slide each. What is SU we have learned? This is a time-tested drug, used since 1950. It's a robust glucose reduction when you start with. At least if you see any trial head-to-head with sulfonylurea, at least in first 3 months, SU is the winner. But people does a longer trial when the SU actually loses. So if I stop my trial at 3 months, I will always say that SU will win all this match. This typical Nike pattern of HbA1c reduction, which is so robust and so fast that if anybody concludes the trial in first 3 months, the sulfonylurea will be the winner. But that's 3-month treatment is not the chronic therapy of diabetes. So it has got a good, robust reduction of, it is inexpensive. Anybody can afford. We have got drug which everybody can afford. And we do have the backup data in terms of a randomized controlled trial, and I will come to those big RCTs starting from UK PDS to all, which did not actually show anything wrong. So in UK PDS trial, chlorpropamide and glibenclamide was used at that point of time in mid-1970s, and there was no harm. So suddenly why we are talking about other molecules? There must be something wrong or something good about others, which I'm going to look into. But there are some disadvantages as well, which probably we never looked into, being emotional and being economical molecule to all of our patients. Remember, SU doesn't correct anything in the pathogenesis of type 2 diabetes. It simply whip beta cell to secrete insulin, and that's it. It doesn't correct anything in the ominous octet, and you can right now say dirty dozens in the pathogenesis of type 2 diabetes, starting from when the pathogenesis of this disease start. So merely what we are doing is we are just looking into the numbers of glucose. We are reducing blood glucose. We are glucose-centric, not the disease-centric when we are using sulfonylurea. We also learned that in a head-to-head trial, durability is less. As I said, for the first 3 months, SU will beat any drug. But then what happens after that? The SU were losing their effectiveness once the trial progresses, as you have seen in ADOPT and RECORD trial, when it was compared with glitazones and metformin. In the first 2 years even it was effective, but after 2 years down the line, at 3 years, actually they are having losing effectiveness. Hypoglycemia at a time requiring hospitalization is a major concern, and we don't want to indulge into this consumer court. And if you have landed with this hypoglycemia, if your patient has died ever with hypoglycemia, then we are in the mess. So this is one major issue. There is a weight gain. There is a theoretical possibility of beta cell apoptosis, which has not been proved as yet. But there are some data, experimental as well as the clinical data, where the glibenclamide at least has been seen to abolish ischemic preconditioning. So I would recommend glibenclamide may not be a great sulfonylurea to use, and I would rather be very circumspect in using glibenclamide. But recently, many of the recent observational studies and their meta-analysis suggested some kind of increasingly CB signals with sulfonylurea, which possibly many can say that it is pharma industry concocted, but that's not the reality. Let's look into what is this all data is all about. So this is about SUs, the lessons which we have learned so far. What about gliptins? We have seen, and I will show you the data, that HbA1c reduction of gliptins are at par with SUs. This drug actually do not cause hypoglycemia when used as a monotherapy. These are weight neutral drug. There is a theoretical possibility that this may preserve beta cell. At least data, the animal data is there quite clearly with the GLP-1 agonist. Some data is also with the DPP-4. And the side effect, which we initially thought that pancreatitis or UTI or a nasopharyngitis was the initial concern with DPP-4, is no more existing with this drug. And the best part at this point of time is now we do have results from the long prospective randomized controlled trial like TECOS, SEBERTIMI and EXAMINE with 3 different DPP-4 inhibitors, which suggested the cardiovascular neutrality. And at least in TECOS trial, we don't have any signals of heart failure with Sitagliptin. But then these molecules do have disadvantage. See the cost. DPP-4 is a ubiquitous enzyme present everywhere in the body. So there is a possibility of off-target side effect with the drug, which is not very specific to DPP-4. We also learned something wrong in these randomized trials, like in BIBIT trial with vildagliptin, there was a trend of increased cardiovascular death. And we also saw Sheshagliptin having a significant 27% increase in heart failure, which we actually do not know how it has happened because there is no mechanistic reason. Many may suggest it could be a play of chance. But then these are the concerns still left with the molecule called gliptins. What about the SGLT2? So this is what I am concluding here, but I will show you the data, how I have come to this point in suggesting the advantage and disadvantage. If you look into the trial, HbA1c with SGLT2 is at par with metformin, SU and gliptins. They have never lost to this 3 competitive drug. Durability is much better because we do have now 4-year head-to-head data of dapagliflozin versus glipizide, where the dapagliflozin were more durable compared to glipizide. We also learned that weight loss is the one actual extra advantage along with blood pressure reductions with this SGLT2 inhibitor when you compared head-to-head with metformin and gliptins. But then there are many issues as well with the SGLT2 inhibitor that may not be the big one, but then it is still there, like genitourinary infections, volume depletion, safety. You cannot use in somebody having renal insufficiency, as we know that there is a cutoff on EGFR 45. This drug should not be used. There are some concern in terms of CB data. We are expecting some data from IMPA reg outcome is going to publish after 1 month. in EASD in Stockholm. But for so far, we do have some concern about increase in LDL. We don't know their long-term, consequences of that. We do have some data of increased in CBA in the interim report of Canvas trial with Cana. We also have some concern about fractures seen in some of the trial, and recently DK issue, which will be talked tomorrow by Professor Jargar itself. So I will not go into detail. I'm just giving you the glimpse of the disadvantage with this molecule. So what happens to the SUs suddenly, which were the most popular drug since last 1950s? So when you look into the randomized control trial, there is nothing wrong with SUs. So you have got green signal, except in the 1960s in UGDP, when the tolbutamide was associated with increase in CV mortality, and there's so many reasons behind that. But since then, the UK PDS trial and so on, you can see none of this trial actually suggested anything wrong with SUs. So where is the problem? There is a problem. On all these trials, sulfonylurea was not actually used as a monotherapy. If you look into the UK PDS trial, it was the SUR may start with, but later on it was added with insulin, metformin, everything. So at the end of the study, everything became a mixed match of that. So hardly we do have any randomized controlled trial where SU was used as a monotherapy from start to end, to know the consequence and the result with SUs. This is the biggest problem with these RCTs with SUs. We do have some studies, like in Chicago, pioglitazone was compared with glimepiride in Periscope, glimepiride and pioglitazone again compared in approach. Rosiglitazone was compared to glipizide. So there are some trials where SU was compared as a monotherapy, where SU was found to be inferior. But here you have fought with pioglitazone, rosiglitazone on some surrogate marker. Thus, a comparative understanding of CB issues with SUs is still not known, and we are looking into what lies in the future. But we do have some now emerging observational data which suggested a discordant result which we did not find in the randomized control trial, as I said, because these are not a monotherapy trial. So people looked into the monotherapy trial with SUs, and I'm going to give you two studies. It's one of the largest meta-analysis of combined data. 33 studies were taken in this meta-analysis, consisting of 13 lakhs patients using sulfonylurea as a monotherapy. And when they looked into the cardiovascular mortality, as you can see here, when you take a randomized control trial, there is no harm. When you add cohort observational, and finally, if you look into this data, you could find a 27% increase in CB mortality when you look into sulfonylurea monotherapy trial. Same happened with the MI. When you take a randomized control trial, there's no issue. But when you added a observational case control or a cohort study, again, you could see there is increase of 11% myocardial infarction in the SU's arm on these observational studies. And as I said, I will quote another meta-analysis. Again, this looked into the major adverse cardiovascular outcome, and when they compared SUs with other active comparators, they did not find any difference. That is very good news about SU as a monotherapy. But when they compared with DPP-4 inhibitor, they find something wrong in terms of SUs, or maybe something good about DPP-4, which I'm going to explore you what was those things. So let's come back to the point which I started with. How to analyze which drug should be the best after metformin. So let's go into the punching box and see what is the result. So first, SU versus DPP-4, how many trial was conducted? So let's see where is the data. I will show you some data which is meta-analysis, and I also reviewed on that. So currently we have got 12 head-to-head studies of SU versus gliptins. The 5 with Sita, 4 with Vilda, 1 each with Lina, Sexa, and with Aloe. And when you look into this BG slide, suffice to say that HbA1c level is more or less looks same when you compare gliptins versus SUs. But where the SU is getting inferior is in terms of hypoglycemia. See the very high percentage of hypoglycemia in SU arm compared to gliptins. So when there was a meta-analysis when this looked into this 12 head-to-head trial, and this was the result of this meta-analysis of SU versus gliptins. What they suggested, if the trial is less than 32 weeks, the SU were superior by 0.1%, but the trial was longer than 32 weeks, there was no difference between SU and DPP-4 when you talk about sugar control or having a target HbA1c of less than 7%. But in terms of safety, the DPP-4 always scored over SUs. As you can see, 87% less hypoglycemia, weight gain with less weight gain with DPP-4. In terms of adverse event, in terms of CB event reduction, which is always we are looking into, and the beta cell preservation was found to be superior with gliptins compared to SUs. Out of this 12 trial, actually 4 trial looked into the CB outcome, although it was not the primary design for the study to look into, but on the post-hoc analysis, they looked for the CB outcome. As you can appreciate here, in the SU's arm, the number of cardiovascular events were higher compared to SUs. And we look into this figure into a meta-analysis. This suggests that there is almost 47% CB MACE reduction in the gliptins arm, or the higher MACE in the sulfonylurea arm. Whether it is lower with gliptins or higher with SUs is still not known, and it's a matter of conjecture. There's another meta-analysis by Michael Nock, it's not yet published, he shared with me personally. Here the 10 trials head-to-head compared, again looking into the CB event and the death here, which you could see here in terms of this simple bar diagram. When you compare head-to-head, it is very clear that the DPP-4 inhibitor had lesser major adverse cardiovascular event compared to SUs. Whether it is happening because of the problem in SU or the benefit in terms of DPP-4 inhibitor is not yet known, and that's why I quoted whether the SU elicited CV problem is still not known, but by direct comparison, DPP-4 are associated with less CB event than the SU. Whether this indicates the harm of SU or benefit of DPP-4 needs to be clarified in future trial. Anybody is interested on this debate on SU versus DPP-4, you can see and go into diabetes care. There are 2 commentary published, and you can go into details of whether SU should be the second line drug or not into that. Coming back to the next 2 part of my presentation, SU versus SGLT2. There are head-to-head trials where clearly the SGLT2 were at par with SUs, and some of you can see in 2 studies, in fact, the SGLT2 inhibitor were superior to sulfonylurea even in terms of HbA1c reduction when the trial was longer duration of time. But there was a clear advantage in terms of hypoglycemia, systolic and body weight change, as you can appreciate from this simple bar diagram. Although the HbA1c is similar, but the body weight, systolic blood pressure, hypoglycemia was much better with SGLT2 inhibitor compared to SUs. So what about the DPP-4 versus SGLT2? Again, when you analyze this data, there are 6 trials head-to-head comparing SGLT2 with Sitagliptin in this case. They are found to be equal HbA1c if you compare it. Maybe in last 2 trials when the higher strength of SGLT2 inhibitor was found to be maybe 0.1% superior to Sitagliptin in these trials. But more or less there was a similar HbA1c reduction, but the major advantage over a DPP-4 inhibitor was simply the body weight loss and the blood pressure reduction. As you can see, both hypoglycemia and HbA1c is same, but SGLT2 may have some edge in terms of body weight and SBP. Having said that, there are some issues with SGLT2 inhibitor as well. Should we embrace SGLT2 like anything, like DPP-4, like SUs? Let's wait. There are some issues which needs to be dealt with very clearly. There are some issues with increase in the endogenous hepatic glucose production with SGLT2 inhibitor. There are also some concern about increase in glucagon is to insulin ratio, and I reviewed the literature on this particular issue of endogenous glucose production, and I could summarize you here for you. There is a 17 to 30% increase in endogenous glucose production with SGLT2 inhibitor. It could be happening because of multiple mechanisms by compensatory response or because of increase in glucagon, because increase in glucagon is clearly observed with SGLT2 inhibitor. As you can appreciate here, comparing 2 trials, there is almost 25% decrease in insulin glucagon or 23% increase in glucagon to insulin ratio with these SGLT2 inhibitors. So how to tackle this issue with SGLT2 inhibitor looks to be a wonderful drug. We have got the option. We can use metformin as a first-line drug, which we all are using it. It will stop the increase in endogenous glucose production. We can use something which blocks glucagon, like even the sulfonylurea is a good glucagon reducing drug, or DPP-4 or GLP-1 agonist to decrease this glucagon issues with SGLT2 inhibitor. So before I finish my talk, I would also go into, rather than efficacy, to the safety part. Is the drug at all safe? And we can go through from the tomorrow morning. So this is the paper very recently published editorial in expert opinion, and they compared the safety with the drug. Where the SGLT2 has got still some nick, there's some wound in their body is in terms of safety. And see here, this SGLT2 inhibitor versus DPP4 in terms of different safety profile. And the DPP4 does have clear edge in terms of safety data. In terms of any side effect you mentioned down the line here, the black bar is with the SGLT2, the hollow bar is for DPP4. As you can clearly appreciate, the side effect profile is a little bit problematic. So ladies and gentlemen, what I have reviewed so far in front of you, what we have learned. Let me conclude here. Currently, there is no compelling evidence, although I have given you all the data, that SU truly increases the CV events and still remains a preferred second-line drug for the many clinicians, not here in this country, but in United States as well. The primary reason is it's a very cheap drug. But remember, and we have learned it, that hypoglycemia and weight gain is the major issue. Because of some advantage, at least not causing hypoglycemia and weight neutral, with some 7 years now long experience with a DPP4 inhibitor, with good CV neutrality data which has emerged over a few years, DPP4 are increasingly used instead of sulfonylurea. SGLT2 inhibitors are new kids in the block, looking for the space. Sounds robust to me, at least from the emerging data, but much more experience with this drug is required, especially regarding its safety. Maybe future may belong to them, which I do not know yet. There is one study which might tell us something in more detail. It's called GRADE study, where there's a 4 active arm and 5,000 patients for 7 years, glimepiride in one arm, sitagliptin, liraglutide and glargine is compared for the duration of 7 years to suggest what would be the ideal drug after metformin. But unfortunately in this trial, SGLT2 inhibitor is not there for comparison. So for that matter, we may not be able to know the answer for SGLT2, but let's wait for this trial. We probably will be able to know much better than what we know today. Thank you very much for your patience hearing.
What will be your choice after metformin? And the other thing is, what is the sulfonylurea that was used?
Well, so that is a good question. And the second question was actually, I liked it. And I would like to reiterate here that actually I am reviewing currently the entire articles on SUs, that where we have missed this SU. And I can share with you some data with sulfonylurea, that what I could across, through this reviewing. If we actually remove all SUs and keep gliclazide alone in a sulfonylurea basket, I think the all drug will lose its merit and will become the second line drug after metformin. You can challenge me where from I am suggesting so. If you look into the Dutch guidelines published last year, the Dutch guidelines do not recommend SU in a class. They recommend gliclazide as a sulfonylurea. And remember, the WHO did a trial to learn this, because WHO helps everybody. It is for the poor like IDF. So they did a study with gliclazide in a patient, those who are 75-year-old, in 10,000 veteran FAR cohort. And they find gliclazide doesn't cause hypoglycemia as much as other sulfonylurea causes. And WHO, in their model list of drugs, they included gliclazide with metformin and insulin. For any drug currently which is recorded in the WHO model list of medications, it is metformin, insulin, and recently gliclazide has been included. So you actually asked me a very tempting question. So this SU issue may be sorted out in the future if you take apart the data from gliclazide, then it's a challenge for any molecule for gliclazide. But having said that, all this data has not actually pulled into the gliclazide alone, and they looked at the data with all SU inhibitors, sulfonylurea. So that's actually, translating this into the increased hypoglycemia with sulfonylurea as a matter of fact. But for the first question, what would be the ideal drug? I mean, as I said, neither ADASD could decide. So who I am to decide? You are the best judge. You decide by yourself.
You measure your size and then decide. Professor Mohan, please.
I just wanted to agree with Avdesh that all sulfonylureas are not the same. And I think for example, you do UKPDS, they use chloropropamide, a drug which is now not used at all. Sulfonylureas like glibenclamide, they are the ones which really produce hypo, and many of the things, the bad things which you talked about sulfonylureas, because of a very long-acting drug, so much of hypos. So if you take, my favorite too is gliclazide, and the reason is it's short-acting. So one of the reasons why we don't want to use is marginal renal failure and so on is because we already have a long-acting drug, even glimepiride, nice drug, much better than glibenclamide, but it's long-acting. So if you have marginal renal insufficiency, it gets further prolonged. And the advanced trial, the data from the advanced trial, I think is the best evidence that glycoside is safe. And if you look at head-on comparisons with DPP-4s and glycoside, the difference in the hypoglycemia comes down quite a bit. So that's why in my last slide I had said the patient can afford. My choice would be a DPP-4. There are obvious advantages of that. But the patient cannot afford, a lot of patients in our country cannot afford, then using a sulfonylurea, short-acting one like glycoside will probably fill the gap. And again, don't use high doses of it. So that would be my choice, which
Yeah, absolutely.
One thing, Dr. Desh, when you mentioned about the sulfonylurea meta-analysis, and some of the randomized clinical trials were favoring cardiovascular events. If you go for sub-analysis, how much of them were using, what sulfonylurea was used in?
Yeah, so it was many of the, I will go back to that slide for you, just you can look into, when the Sitagliptin did studies head-to-head with glipizide and glimepiride, and see, I'm here. So this is the slide you are looking for. Oh, this slide, can this slide come in front here? This is just a look onto that. So you have got a study where you are comparing here with varieties of SUs. For the Sitagliptin, you are comparing with glipizide, glimepiride. For the Vildagliptin, you are comparing with gliclazide. As Dr. Mohan suggested, I will just point out here in this one slide, that actually is a very interesting one. When the gliclazide was compared with Vildagliptin, see the Filozof study here. See, the HbA1c was better with gliclazide compared to Vildagliptin. See the hypoglycemia outcome. See the hypoglycemia outcome, although they did not report it in the original study, but on the sub-analysis, there is no difference in hypoglycemia with Vildagliptin and gliclazide. So we do have a head-to-head study, it's called GUIDE study, where the gliclazide MR was compared, means sustained releasing gliclazide were compared with glimepiride head-to-head study, although the HbA1c was same in this head-to-head study, but the hypoglycemia outcome were superior with gliclazide MR. Yeah, Foley's et al. Yes, absolutely. So Foley's et al. Right. So that makes a difference. So there's clearly, as I was referring to, and Dr. Mohan already alluded to, that if you kick out the gliclazide data, it is different. Even Dr. Jargar did one study of gliclazide in Ramadan. It's a completely different. Even Dr. Arbind did the study, and if you take out all the gliclazide data, it's completely a different looking SU, and you will forget that SU may have a severe differences among themselves according to their pharmacological property.
With this, we move to next presentation. I hand over to Professor Jargar.
Last presentation of the day is going to be made by Dr. Shashank Joshi. He's going to talk on understanding current DPP-4 inhibitor cardiovascular safety trials, including TCOS and the implications for future therapy for patients with type 2 diabetes. Shashank doesn't need an introduction or needs one.
I don't need one.
President-elect Endocrine Society of India, past President, Association of Physicians of India, and has been an honorary emeritus editor of JPEF, was editor of JPEF for a long time, continues to be the emeritus editor, and is a very popular speaker in the country, outside the country, represents us in many forums, and everybody is keen to listen to Shashank's last 20 minutes.
So anyway, thank you. I don't think I'll take 20 minutes. And I think I must thank Dr. Jyoti Dev for allowing me to speak on this topic, on something which I don't believe in. Because I think there is no business for CV outcome trials in diabetes at all. Because I think this is all done by a crazy person in US, and there are all these outcome trials and CV outcomes, and they made it mandatory. But I think, diabetes is a cardiovascular disease. But increasingly, there's scrutiny on that CV aspect, because a lot of diabetics die because of non-cardiac causes, like cancers and other issues in mortality. And I'm not so sure whether we should look at every time from a CV safety standpoint. But having said that, I have this topic to cover, which is understanding current DPP-4 inhibitors, and TCOS is the trial under question. So that's what I'm going to do. But what I'm going to really talk in the next 15-20 minutes is diabetes and CVD, why this whole CV outcome trial has become a big thing. It's a lot of money involved in these big mega trials. What was known before TCOS and what TCOS tells us, and maybe the way forward of that. So we all know this very well. I don't think we need to know that CVD is very common in type 2 diabetes. Diagnosis of diabetes is a heart attack equivalent, CHD equivalent. We know it's classically associated with hypertension, dyslipidemia and obesity. We know 2/3 of diabetics die because of heart disease. This number is probably changing. If you talk to Salim Yusuf, he'll tell you that this number is actually changing. And in NEGM, there was a very nice meta-analysis published on this. We also know that a glucose rise of an A1C, every 1% will increase your CV event by 17%, and every 1% increase in that will clearly, have a challenge. So 20% increased risk in CV events. But does lowering of glucose, like an A1C drop, does it really reduce CVD? UKPDS gave us some answer that maybe it's a 14% MI drop, and maybe intensive glucose lowering yet to show CV benefit over standard control. I'm talking of type 2 diabetes, mind you. And that's something which is still a holy grail, and it could even be a counterproductive, as ACCORD trial showed it very clearly. So obviously CV risk reduction is not equal to CV safety. Okay, glycemic lowering may have been shown to reduce CV risk, but the paradox is some anti-diabetics have been shown to increase CV events, and rosiglitazone, which has gone through the whole U-turn, and myself and Dr. Mohan stuck our neck out at that point of time. We were on a hot seat that time. Whenever it is a glitazone, I think we have always been on hot seats. And I think, Steve Nissen, who was that time very democratically oriented, in a presidential pre-year, tried to attack this whole molecule very unfairly, I feel. Because he did a pooled analysis which was questioned by the statistical method that it increased CV events. But of course, we all know all glitazones increase heart failure. So heart failure was clear cut. But that so-called 21 studies which increased at 17% MI and 21% increase of CV events from 25 studies which he picked up, he and Kathy Walskley, really, put a spotlight to the US FDA. Mind you, the US FDA is the only one which mandates CV outcome trials. And he mandated an order after this whole, publication in New England Journal of Medicine. After this rosiglitazone was suspended. The only country in the world which did not ban rosiglitazone and which continues to use rosiglitazone is China. They never banned it. They don't believe what Americans do. They may copy what Americans do, but they don't believe in it. And everywhere else there was a knee-jerk reaction. They banned rosiglitazone. China never banned it. US also never banned rosiglitazone. They only restricted its use, but because of the legal medicine, obviously the whole molecule got killed, and with that more or less class was under whole scrutiny. But after that, in July 2008, the FDA's Endocrine and Metabolic Drug Advisory Committee said that if you need to pass a drug, you need to really do a CV risk assessment, and you need to study the CV risk more thoroughly addressed during anti-hypoglycemic medication development, recommend that it has to have a demonstration of unacceptable increased risk of CV, you don't use that drug, and it is important that every study sponsor has to include patients with high risk of CV events, that means patients with advanced CV disease, elderly people and impaired renal function. So they made it mandatory. So they sort of mandated that in your trial, you need to have people with impaired renal function. In your trial, you need to have elderly patients. You need to have patients with advanced CV disease. And the study duration has to be minimum of 2 years. And then it should meet an endpoint. So it was like sort of a fatwa or passed on them that this is mandatory. You need to do this. So it was there just wisdom, just based on Steve Nissen's hypothesis, which was really hypothetical because if you apply different statistics to that whole rosiglitazone cohort, and now we know very clearly that rosiglitazone is CV safe. If it is CV neutral, very clearly shown. I mean, there's no two ways about it. So there's a whole U-turn on them, and they have put their fingers in their own mouth, the US FDA, but we are so US-centric, we are completely wedded to the US culture. So obviously this was culturally appropriate, and therefore US FDA made it mandatory, and of course, pharmaceutical industry has to spend now billions of dollars doing all these outcome trials. So the FDA put these statistical hurdles for approval. And what were those statistical hurdles? Suddenly we had to all learn statistics. And in that statistics they said that there is an odds ratio. For a drug to be approved, CV safety study post-approval may not be required. There has to be a clear-cut hazard ratio If it is more than 1.8, okay, it is unacceptable. Between 1.3 and 1.8, there is a boundary of question, and below 1.3 it's okay. If it's below 1, it's great. Okay, so this is a challenge which was there. Okay, so obviously if it is 1.3, it is underpowered. If it is between 1.3 and 1.8 hazard ratio, then it is inferior, and it's above 1.8, it's unfair. And therefore many insulins, including say degludec, have been unnecessarily put through this scrutiny, which I feel is completely redundant and stupid. Because now this was meant for type 2 diabetes and was meant for fundamentally CV outcomes in type 2 diabetes for OHAs. And now they have suddenly applied this whole yardstick to insulin, which I feel is again completely crazy. Okay, so I don't really believe in this, but we have to, this is what US FDA mandates, that this is what they want an unity or below unity outcome. And therefore, Avdesh very nicely, my good friend, has put out the SUs versus gliptins and the CV hazard, and what are the outcomes favoring gliptins. And obviously the data is overwhelmingly saying that probably gliptins are a little better drugs, because they definitely are weight neutral, and they definitely have lower hypoglycemia, and probably may have a odds ratio which might have a trend, I would not say clearly superior, which might be towards them. That was really favoring DPP-4 inhibitors. So if you look at the overall risk based on indirect analysis, on risk reduction, okay, overall risk of adverse CV events, the relative risk is 0.48. And a subgroup analysis of significantly lower risk of CV events only with sitagliptin is like 0.37. Okay, so obviously this will differ with different gliptins also. And you can see here that this is a little outlier here with alogliptin going up, vildagliptin around 50%, saxagliptin, and this is again not based on outcome data. Okay, this is just a meta-analysis of CV risk in type 2 diabetes, which was published by Patil et al. In American Journal of Cardiology. If you look at pooled analysis of placebo-controlled trials, that is 67 RCTs, 4 of alogliptin, 8 of linagliptin, 8 of saxagliptin, 20 of sitagliptin, 27 of vildagliptin. And if you look at all these, okay, you can see sitagliptin really scores out here. Okay, of course you have vildagliptin going up, linagliptin going up, but overall you can see that the trend is that there could be an increased risk. If you look at just this analysis by Go Garber, published in 2012 April, that there could be a challenge with vascular disorder with linagliptin. So again we will end up with confusion. And if you look at sitagliptin, probably it's showing 0.83. And I'm not saying this because we are in the Sitagliptin Symposium. So what we know is some of these gliptins like sitagliptin, which is probably the first gliptin which was chemically available to us, though Vilda was first discovered, it had an impact on endothelial function and inflammatory states in patients with CAD and uncontrolled diabetes. It clearly had a lipid issue which was favorable. In hospital complication rates, post-acute coronary events, it had a lowering of impact on them. And on myocardial performance during dopamine stress as well as reduction of post-ischemic stunting was observed. Also, there was data to show with sitagliptin before TCOS. What do we know? Is it as effective as a conventional oral agent? And probably the answer is yes. Is it more durable than sulfonylureas? The answer is yes. Is it having a lower risk of hypoglycemia and weight gain? The answer is yes. Does it address surrogate CV markers? Probably yes. Does it have a pooled analysis for a better CV safety? The answer is yes. So, if you look at a conventional secretagogue and if you head to head compare it with sitagliptin, probably it is effective, it is more durable. The only challenge with secretagogue is its non-durability. Hypoglycemia, weight gain, clearly it's there, the advantage. And on surrogate CV risk markers and CV pooled analysis, it is there. Long-term CV and non-CV and safety in population with a background CVD is the one which needs a CV outcome trial, if you go by the US FDA mandate. But two gliptins were very over-enthusiastic. They were doing their own CV outcome trials. One of them is a Japanese gliptin called alogliptin, and another one is an American gliptin, saxagliptin. And they were looking at getting the endpoint quicker and faster. Again on outcome trials. The ALLO trial is very well known to us, the EXAMINE trial, and SAVOR-TIMI, which was done by one of the leading cardiologists in the world, Eugene Braunwald's team. That was a SAVOR-TIMI trial. And when they looked at it, they picked up another thing, that there was increased hospitalization of heart failure. And both the trials had a hazard ratio with, for examine it was 1.19 and for SAVOR-TIMI it was 1.27. So we had now something coming up. Obviously the incidence of heart failure did not go up, but the hospitalization for heart failure did go up. So a new concern came up again, and thus therefore a question was asked in general, that does sitagliptin increase the risk of heart failure? That's a question which we will know, because are the gliptins different? Is it a class effect? Because obviously if you look at these two outcome trials, the answer is that there looks to be a trend. This can be debated, of course. You can have a whole debate on hospitalization of heart failure. Okay. But clearly there was a concern which was raised on hospitalization of heart failure. So let us look at, we are all daily wage earners, we practice every day. Let us look at a 59-year-old male school teacher, diabetic for 9 years, stable dose of metformin, underwent a CABG a year back, dyslipidemic, hypertensive, well managed, current A1C is 7.4%. What is the glycemic target for this patient? What should be your next step? Can we continue usual care or up-titrate current therapies? Can you add in such a patient, say for example, a drug like sitagliptin? Because we all see patients every day, so can we really add that? And which should be an add-on agent which will be effective and which will not increase any CV hazard to this patient? Because mind you, he is a diabetic, he has dyslipidemia, he has hypertension, he has underwent a coronary artery bypass surgery, and do we have the confidence of adding a gliptin here in such a patient? And that is what probably I am trying to look at. And this was exactly a prototype patient. And I borrowed that actual patient from Dr. Sethu Reddy, who now is at Jocelyn. He used to work formerly with Merck. And this was the question which was asked by the TCOS investigators from Duke and Oxford. Does sitagliptin increase risk of CV events when it is added to usual care to a type 2 diabetic with pre-existing CVD? A lot of people ask me, what is this TCOS all about? TCOS is nothing but looking at safety of sitagliptin. Is it increasing the risk of CV event when you add it to usual care of a type 2 diabetic patient who already has a pre-existing cardiovascular disease? So I have tried to make it in a very simplistic manner so that we can understand this question better. So obviously, initiation of TCOS actually was much prior to the US FDA mandate. Okay, US FDA mandate came a little later, it came in 2008, but TCOS was initiated much before that, but design was later on modified consistent with the US FDA guidance. It is the longest CV outcome study within the class because its median duration of follow-up was 3 years and it has a global footprint. In fact, I am very happy to know that it had 30% of the patients from Asia Pacific and 12% of the patients from India alone, and people like Dr. Mohan were all investigators. It is a very pragmatic design because it reflects usual care. Patients were managed by healthcare professionals, what they were doing usually. They were trying to achieve the same targets irrespective of sitagliptin or placebo, and it was led by academic centers, Oxford and Duke, as a joint collaborative program. So obviously, the study population were type 2 diabetics, an A1C of 7.2 plus or minus 0.5, stable background of anti-diabetic medications. They were either on a monotherapy or a dual combination therapy. Average age around 65 years. All of them had pre-existing cardiovascular disease, which means they had either history of myocardial infarction, coronary revascularization, angiography with at least 150% stenosis, history of ischemic stroke, coronary artery disease with at least 50% or more carotid stenosis, or peripheral artery disease with objective evidence. That was the inclusion criteria. Type 2 diabetic, stable background of anti-diabetic medications, around 65, 50 being the cutoff, and pre-existing vascular disease. That was the study population. They excluded type 1 and DKs. They excluded patients with severe hypoglycemia in the last year. They excluded patients who were having eGFR less than 30. They excluded patients with other incretin-based therapy or rosiglitazone, cirrhosis, planned revascular procedure, pregnancy or planned pregnancy. But look at it. The patient recruitment was from 2008 and July 2012. North America contributed only 17%. Latin America 10%, Western Europe 14%, East Europe 27%, Asia Pacific 31.1%. So obviously it had a real global footprint. It was there across the world. And obviously the diabetes is in Asia Pacific, and therefore it was truly a representative trial including 14,671 patients, and almost 15% of the trial patients came from India. It was a very randomized design with ITT. Around 7,000 plus patients were Sitagliptin added to usual care, and another 7,000 placebo for blinding was added to usual care. And usual treatment modification to achieve targets was in the Sitagliptin group, usual treatment modification to achieve targets was in the placebo group. They were followed up every 4 months for the first year and every 6 months till the end of the study, and continuous treatment modification was allowed in both the arms to achieve glycemic goals. BMI around 30 plus or minus 5, CVD 100% on both the sides, heart failure because that came under a lot of scrutiny, 17.8% in Sita group, 18.3% in non-Sitagliptin group. Use of other medications, metformin 80% in both the groups, secretagogues around 45%, glitazones only 2%, mind you. See how the glitazone have changed, because this was just in December 2008 when rosiglitazone was at its peak. Because the FDA mandate came out just a month and a half before that. Insulin around 20%, and the median insulin dose again was pretty high, 50 units in each group. Treatment modifications were allowed in both arms to get glycemic equipoise, and other cardiovascular factors like BP and lipids were similarly managed. So obviously there was a glycemic equipoise. You always need a glycemic equipoise, and you need to have the same A1C when you are looking at CV outcomes on a background of stable CV disease. So obviously, what were the study endpoints? The primary study endpoint was time to first occurrence of a composite CV endpoint, which is CV death, non-fatal MI, non-fatal stroke, hospitalization for unstable angina. Most other CV outcome trials, particularly Examine and Savor TIMI, did not have hospitalization for unstable angina. So this is an additional feature which TCOS had. And then of course you had secondary endpoints, time to occurrence for composite endpoint of non-fatal MI, non-fatal stroke, CV related death, first confirmed component for the private outcome, first fatal or non-fatal MI, first fatal or non-fatal stroke, all-cause mortality, hospitalization of heart failure or CV related death, and then secondary endpoints were change of A1C over time, renal function, both eGFR or urinary albumin to creatinine ratio, time to initiation chronic insulin therapy, time to add a next co-interventional agent, and medical resource utilization, that is hospitalization and outpatient visits. So obviously the glycemic control over the study was pretty consistent. You can see here, which is published now in the New England Journal of Medicine. Anti-diabetics were adjusted in both the groups to achieve glycemic equipoise. It doesn't mean that Sitagliptin is inferior. It was just for the trial purposes of the study, a glycemic equipoise was maintained. It's not inferior at all. And you can see that the A1C drop was consistent over a period of time, and the least change statistically different was 0.929%. Obviously, potential CV benefits of glucose lowering with Sitagliptin could have masked CV hazards, and that is the reason to have glycemic equipoise. And therefore, individually appropriate A1C targets in all patients was aimed, and both the arms, the A1C had to be close to exactly similar levels. And that is something the biostatisticians tell us, and therefore a type 2 patient with CVD with a target A1C around 7% is not easy to handle. And then in the Sitagliptin arm, when do you have anti-diabetic medications? Initiation to the next anti-diabetic medication, hazard ratio was 0.72, and initiation of insulin, the hazard ratio was 0.70. So it had lesser additional therapies compared to the placebo arm, which is obvious. There was no increase in the CV hazard. So primary endpoint, clearly the hazard ratio was 0.98. You can see it is absolutely clear, which included all the four, not just CV death, non-fatal MI, non-fatal stroke, but also hospitalization for unstable angina. So clearly it is safe. In the secondary composite CV outcome, again, no increase in the CV hazard. So that was also having a hazard ratio of 0.99. So again, safety was documented. And what was most reassuring, everybody was looking at Boston to the heart failure. Because of the two previous trials showing the heart failure, it was absolutely at 1. Okay, hazard ratio of 1, no increase in heart failure, and that was very reassuring in the Sitagliptin versus the placebo group. Hospitalization of heart failure was almost the same, 3.1% in each of those arms. So no increase in heart failure early or at any stage of the study. And renal function over 4 years, as seen in previous studies, average rate of decline in GFR may be 4 ml per minute per year, and it was not related to any baseline level of GFR, and it was very, very consistent in both the arms. And obviously, this was something for us to be very assured about. So summarizing, no increase in the primary CV outcome when sitagliptin was added to usual care. Even on secondary composite CV outcomes, no increase added to usual care. No difference in rate of hospitalization of heart failure. No increase in incidence of severe hypoglycemia, infections, death from infections. What was significant was the cancer outcome. Overall malignancies were lesser. No increase overall incidence of acute pancreatitis and pancreatic cancer, because another concern which has been often linked with gliptin as a class, and sitagliptin in particular, has been pancreatitis and pancreatic cancer. So all those assurances, I would say TCOS is a very assuring trial. It assures and gives me confidence that it doesn't have all these side effects. And the sitagliptin arm had fewer additional anti-diabetic drugs and less likely to get insulinized. So obviously, does TCOS say that sitagliptin is no better than placebo than CV risk reduction? No. Clearly, you can see that TCOS tells us that sitagliptin is a very effective anti-diabetic agent. It does not increase any hazard in patients with background CVD. That was the primary objective. Does TCOS tell us that is it just safe when in usual care? Because it was added to usual care. We have conventional drugs like metformin, sulfonylureas, pioglitazone, insulin. They are all similarly distributed at baseline in both sitagliptin and non-sitagliptin arms, thus practically nullifying all the protective and hazardous roles of any one of them. And therefore, obviously, the only differentiating factor was placebo or sitagliptin on background CVD. So coming back to the case study, which of these drugs are backed by evidence which have to be added in that patient as a safe add-on to metformin? Is it secretagogue? Is it pioglitazone? Is it insulin? Is it saxagliptin? Is it sitagliptin? Is it vildagliptin? And I am not going to answer that question. That's for you to decide what you want to do. Now, how do you compare CV outcomes of gliptins? Well, if you look at different trials, the first came out allogliptin. Okay, they picked up acute coronary events, 5,000 patients, presented in September 2013 in the European College of Cardiology, and saxagliptin almost at a larger group of 16,000 patients with pre-existing CVDs, presented again in September 2013, and sitagliptin was presented in June this year, and of course linagliptin, carbolinol will only come in now in Jan 2018. Vildagliptin, of course, we all know do not have any ongoing safety trial, and it's very unlikely to come. But look at the different groups. Sitagliptin is mainly in a stable group. Saxa was in the risk factor to stable group, and allogliptin was in a post-ACS group. So obviously, if you look at examine, severity and TCOS, the primary endpoints are different, but they all were neutral. If you look at baseline characteristics, they are very different. For Saxa, Allo and Sita, is Savertimi 53, Examine and TCOS. As I said, that they all had a different background. Duration of disease, A1C similar, mean age similar, BMI similar. If you look at baseline cardiovascular characteristics, again if you see there is some similarities, some dissimilarities there, and baseline medications again similar. But if you look at the primary outcomes of all of them, there is a test of heterogeneity for the three trials. But if you look at it overall, it appears that even as a class, this is a safe class to use. And you can see here acute pancreatitis, chronic pancreatitis, pancreatic cancer, again head to head, you can see very clearly, it's very reassuring from all these trials which we have seen together. Are there differences between Savertimi and TCOS? Yes. Because Savertimi was initiated from USAID directive for CV safety. TCOS was self-initiated. The study population is different. TCOS was clearly established CVD, while in Savertimi, risk factors with CVD as well as pre-existing CVD taken. The duration of follow-up, 2 years only with Saxa, 3 years with Sita, so it's a little longer, but the number of patients was 16,000 plus with Saxa compared to Sita of 14,000. Duration of diabetes.
Couple of more minutes.
Yeah, I'm almost done. Okay. BMI almost similar, A1C very similar. And as I said, that the only difference between the two trials was the hospitalization due to heart failure. And that probably had a hazard ratio which TCOS really assures us. So it was the heart failure which probably differentiated hospitalization of heart failure, TCOS from SAVER, and I would not go into details of that because that has been a well-established fact. So probably this is my last slide, that when you manage a patient with type 2 diabetes with CVD, what has TCOS answered? That it's an effective, durable add-on therapy to bring the patient to target with low risk or no risk of hypoglycemia and weight gain, and there is no increased CV or non-CV hazard. It has been studied in all 4 NYHA classes of heart failure, and there is no increased risk of heart failure or hospitalization due to heart failure in such comorbid patients. So I think that was the conclusion I can take in the post-TCOS era. Thank you for a patient hearing.
Yes, please, Arvind.
I want to ask Shashank the same question which the other people have asked to Avdesh regarding the sulfonylureas. Sulfonylureas, as you have said, and Avdesh has given the meta-analysis and the advance, he has never mentioned advance in his presentation. You have clearly, Dr. Mohan has clearly mentioned about the advance. There are some issues about the hypoglycemia, weight gain and ischemic preconditioning. People are using these sulfonylureas for years together. We have also patients and they must be having the patients. They never have hypoglycemia, severe hypoglycemia or hypoglycemia hospitalization, if the patients are taking proper care. So, I mean, this is what I was to ask about still what is your idea about the sulfonylureas? As we are not comparing with the DPP-4 inhibitors.
So I think we are looking at a very unfair comparison. Gliptins are born in a class at a time when there is intense scrutiny, doubt, and safety is paramount. Efficacy has never been the question, it has been safety. And they were born in an era when rosiglitazone controversy was right under their nose. Okay, so obviously the era in which they are born is very different. But clearly their advantage is weight neutrality and their advantage is no hypoglycemia. Clearly. Secretagogues were born in an era of controversy. Tolbutamide, very clearly they showed in a very nice way, had this challenge. I don't even know whether that was true. After that, every other trial had an add-on. Advance is a good trial. Gliclazide has a differentiating point. I feel glimepiride, gliclazide have their own challenges. I personally, like Dr. Mohan, we both probably in a renal situation would prefer a gliclazide followed by glimepiride. They are the next generation secretagogues. In a resource limited country like India, we cannot skirt them away completely. Having said that, recurrently retrospective databases have shown that secretagogues are not above board. And we do not have systematic CV outcome, okay, which shows a positivity for any of the secretagogues, including gliclazide. Even advance doesn't show any, it is only a renal arm which might show a marginal improvement, but it may show neutrality at best. Okay, so I am not so certain that we should be still wedded to secretagogues. Secretagogues in a resource limited environment, sheerly because of their cost, will always stay. In a reimbursed environment of North America and Europe, they might have their obituaries written. But I don't think you can ever skirt them off ever. Also, in a lot of countries like India, China or Africa, you will continue to see secretagogue use despite of gliptin use. And I am certain that many of us in this audience have patients who will have secretagogue, metformin and a gliptin on board. I would like to take a show of hands here of practicing doctors who have all the 3 agents on board. Can I, because I think all of us almost have that. So I don't think the era has come where you can do away with a secretagogue. Okay. Having said that, gliptins have stayed and will stay and are clearly going to be there. I don't think you can decry gliptins either.
Any more clear? Yes, Prof. Can we have a
Did any of the patients in the TCO study, were they in heart failure? Yes, they were. No, but ultimately you have said that it didn't increase. Did it increase hospitalizations in that group?
No.
Unlike the other.
Unequivocally, no.
So it's not a class effect.
The point is that the heart failure was the same in the placebo arm and the sitagliptin arm. Not that heart failure didn't occur, there was no difference between the two arms. And therefore, this drug, the whole aim of FDA is, if you give any anti-diabetic drug, whether it's insulin or any oral drug, does it have any CV side effects? Is it harmful from the CV point of view? In this particular trial, it is not harmful. That's all we can conclude.
I think there's one more study, I think. You mentioned there's a Carolina study and a Carmelin study. Two more studies. I think you showed one. There's one more. Yeah, I think it is under trial. These two studies.
Yeah.
You showed the Carmelin. But
Yeah.
there's a Carolina also.
There is no result of Carmelina as of now and Carolina. Carmelina,
No, I think it's ongoing.
Yes. I will come back to, I will just come in 30 seconds to Dr. Arvind Gupta's question. I think there is one confusion maybe with us that advanced trial and gliclazide is very closely associated. Yes, the name suggests the pre-TRAX trial, but please remember that in advanced trial, it is not the only gliclazide. Again, I came to the same theory. It's not a monotherapy trial. All the arm in the gliclazide arm were having associated concomitant therapy with pioglitazone with insulin. And in the other active arm, only gliclazide was not used, but other SU were used. So we actually cannot say that advanced trial was only with gliclazide. It was a combination of variety of drug, predominantly gliclazide. And let's not forget that in advanced trial, there was a circumstantial evidence of hypoglycemia also with the gliclazide. So only making example of advanced trial by saying it will not be fair, because for the example in echo trial, majority of the patients were on glimepiride. So we can't say that because of glimepiride, there was increase in the mortality in the echo trial.
Yes.
Thanks a lot. I'm Dr. Atul Kalhan. I'm very lucky that I've caught up Dr. Joshi in the last 20 minutes. I'm from Cardiff. It took me around 24 hours to reach here, so I reached around 7 in the evening. Fantastic presentation, Dr. Joshi. I just wanted to ask you one thing about, you mentioned about the efficacy of DPP-4. What's your experience with the SGLT2 or the GLP-1 analogs? I just wanted to ask you about you gave a very wonderful example of that.
Not a part of today's debate. We're talking about Gliptin. This is a Gliptin Symposium.
Yeah,
I think probably you just missed the talk Avdesh talked about. Your answer is that SGLT2 efficacy to efficacy might be a little better than maybe a Gliptin, or a GLP-1 analog is definitely better. There's evidence to show that. Having said that, Indians respond better to gliptins. Dr. Mohan was the first person to publish that study on Sitagliptin. And Koreans and Indians, because of the higher carbohydrate load, the L cells are more exposed, and therefore they're 0.6, 0.8% of A1C reduction, which has been shown with the Caucasians. Probably with Indians, it can go right up to 1. And we have seen that in clinical practice. So that's a little different from that standpoint. I think one more thing, again, as a caveat on CV outcomes, is we are totally Americanized because of Steve Nissen. We need to put this CV outcomes in dustbin. I don't think we need CV outcomes in diabetes. I am very clearly convinced on it. I think FDA, just because one American FDA decides to have CV outcome trials, we should not be subjecting these CV outcome trials. They may be good for trialists and investigators, but I think it's a waste of time, studying all these CV outcomes and statistics and adding to confusion. Every trial has added more confusion and not cleared any more doubts. Okay, so I think we are just becoming statisticians and analyzing all those endpoints. It is a complete waste of time for clinicians, because we cannot be CV-centric. Then we'll become cancer-centric. We are, at the end of the day, we need to be glucose-centric. We need to look at the overall. The most important thing is the ABC, A1C, blood pressure and cholesterol. We are forgetting that, and we are getting into all these outcome trials. It's a waste of resource.
Did they
I think, I think we have had sufficient time. I think now...
No, whether the TICO study, have they done an echocardiogram and shown that there was
it
no
is
fall,
now, Professor,
no fall in the injection fraction?
Professor, TICOS is now in public property. PRECOS is not investigators' purview only now.
No, whether they have an echocardiogram injection fraction, and whether there's a fall.
None of the trial it was done. It was not done.
So there could have been a fall in injection fraction.
We can't get into that now after 8 years. I think, it's really delighting that we had a focused symposium on gliptins, but speakers did an awful job. We talked about, Mohan talked about the use of insulin in the first, and he clearly showed some benefits, that if you insulinize early, you will have fantastic results, and you might have nothing to do for next 3.5 years. And next, Krish did a fabulous job telling us about not only the biology of glucagon, but its evolution, and how we are over-focusing on insulin and forgetting a key molecule, that if you do not have that magnitude of hyperglycemic diabetes may not come. So a totally new insight into the whole thing. I think Audit did an amazing job. And one liner which I would like to reiterate that Mohan said, whenever we are talking about sulfonylureas, we are bracketing a huge class together. Way back in 71, when UGDP study was terminated, after 8-9 years, tolbutamide was the drug. Then chlorpropamide, the half-life of which was 72 hours. It's a totally different class of drug. Gliptin would continue working after 48 hours and give it 6 half-lives, and you see how long it will remain in the system. Individual drugs are different. A lot of different data is available on glycoside. Some drug that still is being used on 60% of people in the Western world. But gliptins, they have their own role, and I think the comparative analysis that Avdesh did was awesome. Every drug has a role, and every drug targets a particular aspect of pathophysiology of type 2 diabetes. And given the fact that in this nation we have so-called currently 6.5 crore diabetics, all of us do believe it's a very heterogeneous disease. And a heterogeneous disease that we catch up at a hugely different stages in the natural history of that disease. So drugs have their own role. And at the fag end, I also do second Shashank's this. It's very difficult. Every time you have a heart attack, the coronary artery disease has been on for 2 decades. And how do you determine the CV outcome of a drug in 2 years or 8 months or 12 months or 3 years when concomitant you are using half a dozen other drugs? You see, tell me which ethical committee today, all these TCOS people had already proved coronary artery disease when they are followed. Tell me which ethical committee would prevent people using a mega dose of statins. And there was a subclass which is using pioglitazone as well. If you look at the Sitagliptin part, they ultimately found out that the individuals who had higher failures, they incidentally, there was statistically increased number of people on pioglitazone. So the whole gamut, I think these elegant speakers, the stars have really done a starry job. Now it is your job. They might have left you as confused or as empowered. They have empowered you with knowledge, understanding, and comprehension. So at the fag end, we come back to what Avdesh said. Second line is for you to choose. Thank you very much for this wonderful evening.